Okay.
Hello, everyone. Welcome to Hot Seat Season 3. Once again, I'm so happy to be with you all from this educational platform. And as you all know, over the past seasons and over the past sessions, we try to cover almost every aspect important in implant dentistry and periodontology and how we can make the treatment outcomes for our patients as predictable as possible with great speakers and guests from around the world. And today I have a very dear friend, very talented surgeon from Japan. Dr. Eiji Furichi is here with me on Hot Seat. Hello, Eiji, and welcome, my friend.
Hello. Hi.
Thank you for joining. And today, Eiji is one of the Dental XP experts, and I had a chance to know him from Dental XP. He's super talented. And in Facebook, at least, we call him Perio Ninja, because the way that he treats cases is amazing. When you see from the start to the end, you will be mesmerized by what he do and, what possibilities we have in our field in treating our patients. So we should be aware of them. And today, the topic that Eiji gonna talk about for us is saving teeth and true treatment endpoints in the implant world. But before Eiji start the presentation, I would like to have a short CV of him for all of you, and then he can share his presentation and we can learn from his ideas. Dr. Eiji Furichi graduated from Osaka Dental University in Japan, 1992, and then he founded a private practice in Kobe Hyugo in Japan in 1998. In 2005, he obtained PhD in orthodontics from Osaka Dental University, and in 2014, Carnival and Furichi Periodontal Aesthetics Center in Japan was set up by his master. He's a dental XP expert and has lectured worldwide, also member of American Academy of Perio, active member of NPG, and so many other associations, also an expert at oral surgery too. Once again, I'm so happy to welcome Eiji to Hot Seat in our season 3. So Eiji, the platform is all yours and we are ready to learn from your great cases.
Thank you very much.
Thank you. You can start.
Okay. Start?
Yeah.
Yes. Saving teeth and true treatment endpoints in an implant world. Thank you very much for taking the time to hear about my cases. I'd like to thank the entire Hot Seat staff. I'd also like to thank my friend, Dr. Omid Moghaddas, for inviting me to this wonderful event. My name is Eiji Furichi. I'm from Kobe, Japan. Being able to participate as a speaker at this exciting event is a great honor. I have a PhD in dentistry, and I specialize in periodontology, implantology, prosthetics, and aesthetics. The theme of my presentation is periodontology, implantology, and prosthodontics. I will show you that teeth can be saved, and usually in the final restoration process using periodontal resective therapy. And I will show you some clinical cases to talk about what true treatment endpoints are all about. And now, I would like to begin the presentation of the crown lengthening procedure. I think it's a very important technique, and we often have to use it to save teeth. I'll show you this case. Her chief complaint was an unappealing aesthetic appearance of the anterior teeth. The smile at the initial visit. Roberto Pontoriero and Gianfranco Cannavale reported that gingival growth continued for around 1 year after plan lengthening, with a mean growth of approximately 3 millimeters. Even if we wanted to start the preparation within 1 year, we need to wait for at least 6 months before we set a slightly shallow finishing line with the preparation margin. We open the flap using a surgical template. If the patient agrees, any tooth at risk of elongation should be orthodontically extruded. We carefully performed osteotomy, taking into consideration the gingival margin of the final restoration. During surgery, it is very important to avoid removing more bones than necessary and avoid removing tissue from areas where no removal is needed. You should use a partial thickness flap. If you open a full thickness flap, there is a risk of demineralization of the alveolar bone and unwanted absorption. A full thickness flap can also lead to long attachment and consequent recurrence of a periodontal pocket due to the fact we can't place the gingival flap in an ideal position. Connective tissue was sutured into place. Suturing was done gently, without tension. By 1 year after surgery, the gingival margin had increased about 3 millimeters, which is important to consider when forming the bone, setting the flap, and suturing. A 20-year follow-up performed by Gianfranco Di Febo et al. Of 100 patients found 854 out of 948 breech abutments were still in function, which equal to a 90.1% success rate. This shows that breech-based prosthetic treatment is a highly predictable treatment, which should be adapted instead of implant treatment when a defect is present on both sides by teeth which need prosthetic treatment. Relying on an implant treatment in such case would further increase risks. We used a fiber post-core set with for META MMA TBB resin. We created a mock-up the tooth and silicon index to carefully study the amount of tooth reduction which has to be done evenly and correctly. After that, we completed the preparation by setting the finishing margin line slightly shallow without damaging the tissues. This was performed 9 months after surgery. We made another diagnostic workshop and used it to create the final restorations. We decided on the inclination angle, line angle, shape, interdental space, and surface wave before checking the final form. I fitted the final restorations. We used layered zirconia crowns. The tooth axes were set based on the upper anterior teeth. We were able to achieve a beautiful outcome. Here you can see a picture and an X-ray of the anterior teeth. This is a patient face and her smile at the end point. We succeeded in creating a beautiful smile. These are the endpoints. Here is a view at 22 months. Now I will show you two more cases. How did these cases reach the endpoints? The last two cases are extremely complex. So now I will show you the full mouth treatment. Now here's case one. This case is of a patient who needs intense periodontal treatment in the entire mouth and has serious aesthetic issues. This patient is a female in her 50s. She came to me for a swelling pain in 2027. These are images taken at the initial visit. I extracted the tooth number 27 as an emergency treatment. These are occlusal views of maxilla and mandible. This is a panoramic X-ray image taken at the initial visit. Here are 13 dental X-ray images. As you can see in these X-rays, severe periodontal disease is present and apical lesions are found. There are also long post-scores. After removing the prosthesis in the mandibular anterior region, I fitted the temporal crown cutting between teeth number 11 and 12. Then I pressed the rapid expansion appliance onto the maxilla. Here, I'm cutting the maxillary middle region towards the palate. This expands the maxilla, as you can see here. Then I created a space between teeth number 11 and 13 using an open coil. For the mandible, I elevated the teeth which were inclined lingually using a lingual arch. I socket lifted the teeth number 26 and 27 and pressed the fixtures. These are X-ray images. While extruding the maxillary anterior region, we pressed down the mandibular anterior region at the same time. We created a space we could press to number 12. Now, we have more space in region number 12. Then we created the diagnostic workshop, a silicon index, and we checked the preparation and the teeth positions. We decided to extract tooth number 21 and further increase the formation for teeth number 11 and 22. These are views of the maxilla and mandible before and after expansion. This is the first diagnostic workshop. We made the first provisional restorations. These are the first provisional restorations. After extracting tooth number 21, I preserved the socket by grafting by wires. These are images taken with the provisional restorations fitted, and that's her smile at this point. These are maxillary and mandibular occlusal views. This is a comparison between fiber retention ORS and ORS treatment of infrabony defect of 3 millimeters or less. At 1 year follow-up, similar results were confirmed with regard to pocket removal. Fiber retention ORS treatment showed lower regression, bone loss, hypersensitivity, and disease ratio than ORS. Fiber retention ORS is a primary option for periodontal pocket treatment in cases with narrow and medium level molar infrabony defects and is more suitable than traditional ORS. I performed the fiber retention ORS treatment by opening a partial thickness flap. Then I performed fiber retention ORS for the mandibular anterior region. Then I did maxillary crown lengthening and CTG. Then I sutured. This is the final view of the surgery. I performed fiber retention ORS with a partial thickness flap for tooth number 44, 45, 46, and 47. Then I sutured. I performed fiber retention ORS for teeth number 34 and 35 with a partial thickness flap and regenerative therapy for tooth number 36 using autogenous bone. Here, I am opening a flap. I am collecting autogenous bone from the mandibular posterior ring. These are views of osteoplasty. Here, I am performing osteoplasty for the lingual region. I am grafting autogenous bone onto the bone defective area. Then I sutured. I performed free gingival graft for region number 26. This is the diagnostic axis for maxilla. This is the front view. Occlusal views. We fabricated the second provisional restorations. Here is a view of the provisional restorations at completion. Side views. Occlusal and front views. These are X-rays taken with the provisional restorations fitted. Front view. Primary situation. Provisional restorations. We finished the final preparations and we took the final impression. These are the images of the mandibular teeth before and after preparations. We took the festival transfer. I started fabricating the final processes from the maxillary anterior region and made a mock-up. Then I slightly recontoured the mandibular anterior region. This is the view after recontouring. Then we check the table of the processes on the mock-up. If everything is good, we go on and fabricate the final prosthesis. Using a silicon index, we check the thickness of the porcelain material. Then we build up the porcelain. We then check the foam family and corrected it. Foam correction was completed. Then the final processes were complete. These are the final processes. These are the final restorations fitted. We performed the Sri Lanka pull-in process. Trial fitting of the restorations were good, so I adhered them. This is after the porcelain only was adhered. Here are the lower right molars. Final outcomes of the upper, lower left, and right molars. Occlusal views after fitting the upper and lower prostheses. Finally, we have reached the two treatment endpoints. Final outcome. This is a great result. Panoramic X-ray before treatment. Panoramic X-ray after treatment. Shown here are 13 dental X-ray images before treatment, and 12 dental X-ray images after treatment. Periodontitis has healed, and the alveolar ridge line is also very clean. Primary station. Final outcome. Here are initial and final restoration images. Now you can see the patient's beautiful smile with the final restoration fitted. Now we can see the patient before and after the treatment. It is an amazing difference. This is the last case. This is a case where occlusion is clasped in the entire mouth, causing serious acidic problems. We need to reach ideal treatment endpoints, even in cases as complex as this one. In addition, we need to do our best to save teeth as long as treatment is predictable. These are the patient's initial conditions. The patient was a man in his early 70s. He came to me hoping he'd be able to eat properly and look good after treatment. Are these the true endpoints? These are images of the study model. This is the patient's face and preoperative front view. You can easily see how poor his oral conditions are. Do you opt to hit full dentures or use implants after extracting all teeth? These are occlusal views of the maxilla and mandible. This is a preoperative panoramic X-ray image. These are preoperative dental X-ray images. Now, what conditions should we have at treatment endpoints? This patient had a dental prosthesis fitted in full mouth. However, does this mean that the correct endpoints had been achieved? Dr. Hugel was the first to establish clear treatment endpoints. These include a probing depth of 3 millimeters or less, a full mouth plug score of 10% or less, no bleeding on probing, and no vacation improvement. However, attaining these intraoral studies does not at all represent a setting in which the true endpoints have been achieved, because we need to ensure correct occlusion and good aesthetics. The true endpoints integrate comfort, satisfaction, function, and aesthetics in addition to the four things I mentioned earlier. Based on a 2008 report by a group of Dr. Rand Nicholas et al., we should reduce the probing depth to 3 millimeters or less. Nicholas et al. Found that the greater the probing depth is, the greater the risk of tooth extraction becomes. Therefore, we have chosen to make it 3 millimeters or less. The crown finishing line is more than 1 millimeter above the gingival margin, or it may be set less than 3 millimeters in the gingival sulcus. After facial transfer, I produced the first diagnostic workup. Then I fabricated temporary crowns and fitted them into the mouth. First, implants were placed at the sites of teeth number 35 and 36. Bone graft material comprising a mixture of autogenous bone and biomass was grafted onto areas where the bone was thin or the fixtures were exposed. Then a bioresorbable membrane was placed on top. Next, I placed the implants at the sites number 45, 46, and 47 using the same procedure. Tension-free suturing should be performed gently and carefully in either a low-to-low or end-to-end anastomosis. These images show the mouth during and 1 day after suturing. As you can see, if suturing is performed with care, the incision will be almost invisible by the next day. Second stage surgery was performed on both sides 4 months after implant placement. Next, with metal frames, we fabricated the first maxillary and mandibular provisional restorations. We attached a hook to extrude tooth number 13. I then fitted it into the mouth. Tooth number 13 is orthodontically extruded. Then I performed surgery on the maxillary and mandibular anterior regions. Mandibular treatment was performed first. I extracted the mandibular anterior teeth, dissected the alveolar bone in the extruded sides, and collected autogenous bone. I placed the two fixtures in a suitable position in the anterior region using a surgical stent that replicated the final prosthesis. Then I performed GBR using immediate implant and bioresorbable membrane placement to minimize changes in the alveolar ridge height as described in the previous paper. Alveolar bone and soft tissue volume in the maxillary anterior region were completely insufficient. In this condition, it is impossible to place implants, perform prosthetic treatment, and reconstruct a natural oral state. In order to suitably position the implants, they would have had to be placed in an area where there is no bone at all. Considerable alveolar bone and soft tissue augmentation was required. This case is class 3, with a wide vocal bone loss. In order to These images are from a systematic review of the survival rates of implants placed in sites augmented with guided bone regeneration using barrier membranes in partially edentulous patients. In controlled clinical trials, no significant difference in implant survival rates was observed between sites of regenerated and non-generated bone. Second stage surgery was performed 5 months after implant placement. This systematic review compares the outcomes of GBR with bypass alone and a mixture of bypass and autogenous bone. No significant differences were observed, and there is insufficient evidence that bypass is superior to autogenous bone for GBR. However, as the use of autogenous bone requires surgical invasion, thereby causing mobility of the donor site, this paper concluded that bypass is preferable to autogenous bone. Here, the flap is elevated. There was insufficient alveolar bone over a wide area, both vertically and horizontally. According to this systematic review, the success rate of implants in sites of regenerated bone was 98.86%, while the survival and the success rates of implants in sites of non-regenerated bone were 100% and 93.2% respectively. The survival and success rates of implants in sites using titanium mesh were comparable to those of implants placed in non-regenerated bone and in sites treated with bioresorbable or non-bioresorbable membranes. This systematic review reports there are no significant differences in the survival ratio between areas where GBR was performed and where the implant was placed within the existing bone. After completely scraping the bone surface, I performed decortication and grafted a mixture of fibrous and autogenous bone collected from the mandible using bent titanium mesh. The titanium mesh was placed on top of the graft material inside the mouth. Then I placed the bioresorbable membrane on top of the titanium mesh. After placing the bioresorbable membrane, tension-free suturing was performed. In the mandible, immediate implant placement and immediate loading were performed after tooth extraction. The left-hand image shows the preoperative oral state. The right-hand image shows the changes at 7 months after operation. Significant alveolar bone augmentation was successfully achieved. Next, I placed in the implant in a suitable position using a surgical stent that replicated the final prosthesis. GBR was then repeated where bone and soft tissues were insufficient. This image shows the oral state after healing. Then I performed free gingival grafting on the left mandibular premolar region. This was followed by crown lengthening on teeth number 25 and 26. The same was applied to teeth number 15, 16, and 17. As there was insufficient keratinized gingiva, I grafted connective tissue onto the buccal and alveolar crest regions, while I slid the flat gingiva in the buccal direction and sutured. These are front views of the mouth at this stage of treatment. Comparing these two images, you can see that there is marked augmentation of the alveolar ridge. Then I fabricated the second diagnostic workup and final provisional lacerations. In order to determine the shape and fabricate the final prosthesis, I marked features such as the tooth root, axis, shapes, and line angles on the model. These are the final provisional lacerations. The left-hand image shows the preoperative oral state. The right-hand image was taken just after the final provisional lacerations were fitted. After fitting the final provisional lacerations, the relationship with the lips must be carefully observed. Then we monitor the patient's post-treatment course. Next, at the site of tooth number 45, where there was only a small amount of keratinized gingiva, I performed only a minor free gingival graft such that the natural line of the gingival junction was not disturbed. This is how I made the final prosthesis. We fabricated it with porcelain-layered zirconia crowns and bridges. The occlusal surfaces are fabricated with zirconia. Here's another view of the complete final prosthesis. Here's, Here I'm fitting the final prosthesis into the mouth. We have inserted the zirconia abutment in the mouth. I've fitted them both in the maxilla and the mandible. This is the final outcome of the anterior region of the maxilla. We have reached the following two endpoints. We were able to create final restorations that took into consideration the following aesthetic factors: tooth position, shape, size, length, color, tooth axis, embellisher space, cervical line, amount of teeth visible when the lips are in the mandibular resting position or when smiling or blinking. Harmony between the teeth lowering, the left and right teeth contacts should be even, make contact at the same time, and the anterior coupling and exclusion at the molars should also be considered. In addition, the periodontal tissue should be healthy with no bleeding on probing. All probing depths are 3 millimeters or less. The full mouth practical is 10% or less, and no vacation involvement. The patient was very satisfied that we could achieve a successful outcome. When the patient smiles, the incisor line of the maxilla matches the lower lip line. Primary station. Final outcome. This is a great result. Primary station, final outcome. These are panoramic and dental X-ray images of the final outcome. This is before and after the treatment. Here are the pre and post-operative views. We achieved near perfect and great results. In conclusion, treatments must be non-aggressive, clean, beautiful, and natural. The most important thing is to save any teeth if a good portion of them is still in a healthy state and is expected to remain in function for 10 years or more. When there is no way we can save teeth, or in case of tooth loss, then the next best thing would be to achieve true endpoints by using either a bridge, an implant, or both of them depending on the clinical condition. In the end, our philosophy is to is that the most important and rewarding outcome is our patient smile. This is my email address.
Thank you so much, Eiji.
Thank you for your time. Thank you very much.
Thank you for your beautiful cases. And as I said, especially the last one was the complete outstanding performance of a dentist, that how you change the scenario for the patient. Even the second case that you show how orthodontics can help us improving the outcome. So your work was truly beautiful, and I have to say I'm so thankful that you shared it with us and you accepted to join the hot
Thank
seat.
you very much.
And you know, you truly are a perio ninja, my friend. Thank you.
Thank you very much. Thank you.
Thank you for
Thank you very much. Wonderful time.
Thank you, and hope to see you very soon. And stay safe, and God bless you. Thank you.
Thank you. Thank you very much.
Bye-bye.
Thank you. Wonderful time.
Thank you so much.
Thank you so much.